Hello again, it's Jason Renault with the Alternative Mobile Services Association, and it's AMSA Talks. This morning I'm with Tony Thrasher with the County of Milwaukee. Welcome, Tony.
Thanks for having me. Looking forward to the conversation.
Tony, tell us a little bit about you and how you got into this business.
Yeah, I'm very fortunate that I'm a psychiatrist, but most of my work and my career has been community based and specifically kind of the crossover between psychiatry and emergency medicine. So a lot of emergency psychiatry. And in doing so, early in my career, I did some outpatient and enjoyed it. Did a lot of homeless outreach and enjoyed it. But I still was missing, I wanted something a little bit more intense than an ongoing ambulatory outpatient practice. And so I eventually found my way to more crisis work through our county, which involve things such as our psychiatric emergency room, mobile outreach, and things of that sort. So that's what I have been deeply embedded in, both local and kind of in a wider reach since probably 2010, roughly.
Tell us a little bit about this beautiful city on the lake. Not all of us have been to Milwaukee.
Milwaukee is a beautiful place to visit. We are near a lot of things. We have a lot of things internally. I always say we're kind of like a large small town. It's a very Midwestern vibe. Lots of good diversity, things to do, and you're also very close to many other places. You're close to Madison, you're close to the Twin Cities, you're close to Chicago, not all that far from Indy. So we got lots of different things that people can do if you're looking for kind of a more Midwestern metropolis.
And of course, the best sports city in America.
They will often, yes, Milwaukee is often quoted as being that. I'm not going to argue with other cities that also want to hold that title, but it is a very a sports centric environment. So no matter what season you're in, I guarantee you there is something being rooted for very close.
We're and how does the city of Milwaukee, the county of Milwaukee, how do they get to needing a mobile crisis team? What spurred them to do this?
Sure. So I would say, I think the first thing to understand is Wisconsin is a little bit different than some states that we are still doing county-based mental health delivery. Many states are regionalized or even pure state top down. The way Wisconsin works is we have 72 counties, which is a lot for our state. Some are very, very small. Some, like Milwaukee, are quite large. Probably the three larger ones in Wisconsin are us as Milwaukee, Dane County, which has Madison, and then Brown County, which has Green Bay. So the way that works is the state gives all 72 counties basically a mental health budget that says, do with it as you will. It doesn't have a lot of oversight. It's pretty much direct funding. And the bigger the
Hmm.
county you are, the more money you have to provide said services for a larger population of people. In addition to that kind of funding mandate, we also have within Wisconsin a specific statute through the state called DHS 34 that mandates how every county must do crisis services. There
Mhm.
are things you are responsible for, such as a crisis line, such as crisis outreach, such as access for outpatient uninsured individuals. These are things you are mandated to do through the state. How each county chooses to operationalize that is up to them. If you're a smaller county, you're probably outsourcing to private companies. Some of these private companies serve Wisconsin, Minnesota, the Dakotas, et cetera. But for Milwaukee, we are big enough and have enough people in need. We're a million plus when you count the suburbs that we need to have an in-person crisis response. Our community deserves it. So consequently, Milwaukee County has always had some degree of ability for people to call a crisis line and get a response from our crisis team. We've actually been around since 1995. We're coming up on our 30-year anniversary on November the 6th. So, and we were probably providing mobiles off and on before then, but as far as a formalized, nonstop, dedicated 24/7, 365 process, it goes back to 1995. So we have been in this world and in this fight and in this growth for some time. So that's kind of how Milwaukee has got ours. There's a fiscal mandate, there's a statutory compliance, and how we have chosen to operationalize that is a full-time crisis service.
That really causes your county commissioners to become much more engaged with the problem.
It's a fascinating issue to your point when it comes to oversight, and we've seen a variety of oversights. To your point, we are overseen by a county executive. There's also an elected board of supervisors. We even have a separate what's called mental health board that is
Hmm.
different than the board of supervisors. So part of our work is engaging with our governmental partners, not just for their own education, but also to make sure that we are utilizing taxpayer dollars appropriately and that they're getting the best return on their investment, which is only fair.
So the funding for your team comes through largely through Medicaid match.
Correct. It's tax levy,
Okay.
grants.
You got a
We
local
also
tax.
Correct. Correct.
Okay.
Yep. So we still have a significant tax levy component to it, grants, and then the funding that you mentioned.
And does that seem to be ample for the moment? What's the situation?
That's a very difficult question. Um, I think right now it's working. I always worry you never want to be too taxpayer levy heavy. Otherwise, I do worry that we are stealing from Peter to pay Paul, right? We're
Mhm.
we're causing significant more financial hardship in a time when there is financial hardship, particularly in people from marginalized populations already living in poverty. But needing the money to provide the services at a high level, you run the risk of kind of creating a circular effect. So I think I don't want to speak for other mobile teams. I think we could always use more funding for more people, quicker response time, and the influx of technology that I think is going to take over mobile services and mental health moving forward as well.
Yeah, let's talk about tech for a minute, but back to the physicality of Milwaukee. You're not an all you're not a live outdoors year-round town. You're
A
it gets a little chilly there.
little
Uh,
bit.
what do you have as far as emergency housing, crisis stabilization? How does the weather affect your team?
Yeah, great question. It is a fascinating. I moved here from St. Louis, and I always say their climates are flipped. But St. Louis was pretty miserable in the summers, but boy, were the winters nice. And vice versa here, the summers are just glorious, and the winters people don't get out much. So we have to prepare for both. You have to have a team that's good at both. We run about a staffing of 30 different mobile team members spread across a couple different areas. And with that, they know how to handle both sets of circumstances. The winter does present its own challenges. So we partner and make sure we have good working educational relationships with our shelter systems. We also have under our DHS 34 that I amended, there is issues of crisis stabilization. So we do have 3 crisis stabilization houses. We do not run them directly, we outsource them.
Hmm.
So there's a private agency that runs them, but they do fall under our licensure. And then we've also been integral in helping to open a couple even what we call crisis resource centers that are not really county mandated or county owned, but we've helped to build them up through a separate private agency. And those are built more for, say, 2 days to 6 days types of stays, whereas our crisis stabilization houses are built for a little bit longer. So we do have, I never think there's enough emergency housing. If we had extra money, I think that's the big thing to kind of invest in right now in today's day and age. But I think we have some stuff sufficient to try to help people around it. And then the rest of it, we work with our local shelters. We work with our domestic violence agencies that often have their own crisis housing. And we work with our child and family services for any sort of issues that may come along with CHIPS petitions or need for kids to have emergency housing, which is a whole nother complexity.
Yeah, so you are seeing youth as part of your, okay.
Yep, we see everybody. We just added in youth in the past 5 years. We were always connected to the youth through other services, but we took it on internally as part of our team. So yeah, we see whether if you're one of those members of the 30, you are going to see adults, you're going to see kids, you'll see people in geriatric ranges as well, as there's certain complexities there with severe and persistent mental illness that changes as people age. So we cover the whole gambit.
Now you mentioned you're 30 years old. Your team is very mature. This must be a great benefit in relationships with all these additional agencies.
I think so. I think it's very nice for them. I think in addition to us being, I like your word mature. I'm going to use that more often. In addition to us being mature, I think another real advantage is that our leadership has been very stable. I think that
Mm.
helps with those relationships too. It's one thing if people are always changing over, but we've had myself as the medical director of said service, our current administrator, Lauren Hubbard, our main mobile team leads, Michelle Leclue, Hannah Keel, and Christina Holloway. We've all been doing this a long time, and they've all had experience both within the crisis services, doing the line staff operations, and then growing towards leadership. So I think those, as much as our team is mature, I think the fact that we have a stable leadership to not just build those relationships, but to be there for different pilot projects. So with those stakeholders, they remember, oh, we tried this in 2020. Didn't work out great, but we
Yeah.
reformed it and brought it back in 2022, and it was a go. I think the fact that those type of leadership relationships have stayed stable, we can't always guarantee that's going to happen, but I think it's of a huge benefit.
So you see an idea, and it might be a good idea, but it might not quite be time yet for that idea.
Absolutely. Well,
Mhm.
and I think once again, I can only speak for our mobile service, but most of the things we do are team based. So it is going to be a partnership. So sometimes maybe it's the right time for your team, but it's not right time for the other external stakeholder, or vice versa. An external stakeholder brings you a great idea that you're like, I would love to do that, and I currently have no funding or staffing to provide. And so, can you catch up with me next year, and we can try to get it in the budget. So I think there's always the trying to find the right time, that fortuitous synchronicity, so to speak, of when both partners are ready to pull it off.
And tell me a little bit about the configuration of your team. Who do you have on this? Who do you hire? Who do you work with?
Phenomenal people, really, really phenomenal people. So, as far as scope of practice, we run about 3/4 master's level social work and some bachelor's level too, but mostly masters. And then the other quarter are registered nurses. So we have a little bit of a mix of both. We don't require either or, but it's been really nice having some nursing background in there too, particularly for a lot of our community issues that have medical complexities,
Hmm.
particularly as we deal with a more aging
Hmm.
population. It's nice to have that background, but we don't require it. Regardless of the social work or the nursing scope, what happens is you then turn into a behavioral health clinician. And that's kind of how we title you and how you are distinctly relegated by the state DHS 34. So that's who makes up our team. We have a very diverse group. We have people that are in their 20s, people that are in their 50s, people that come from different backgrounds, which we really value. We love it when we get people that have already done other work, either in private systems, community systems, child welfare, corrections. And then with that type of knowledge base, it makes for a really good, diverse team. So we can always try to find somebody that best fit the needs of whoever's calling.
We see across the country a lot of turnover, people trying mobile crisis and just finding they can't keep up. What's your suggestion for someone coming into this business and for longevity?
I think there's an onus on the employee, but there's also an onus upon the system, if I can give two answers. I think for the employee, the hard part is to know that you're getting into, I think a lot of people come to us from outpatient and they enjoy the crisis modality, but at the same time, crisis can also be very stressful for different reasons. You're not always seeing the happy ending of the patient doing well.
Hmm.
You're often working with people on their worst days. And that's a great honor and a great responsibility that we take very seriously, but that can weigh on people over time. So I think more than anything from the individual, it's getting them to understand that it's okay to not feel okay sometimes. And it's okay to do the right thing in a crisis and still not feel great about it because you haven't gotten to see it to resolution yet. You've just stabilized a crisis. Systems wise, and this will not surprise you, so many things come down to funding. I think one of the hardest things is when you're in crisis, you are most likely working some off shifts. You're working second shift, you're working third shift, you're working weekends. And if you are somebody who can find a different job, a Monday through Friday, 8 to 4, and no weekends, and
Hmm.
it's for roughly the same compensation, that's hard for us to compete with, even in a mission driven organization like ourselves. And we do have very good retention of employees, I think, because of that mission, because of the stable leadership, because of what we believe in. But it can't keep everybody around forever because families matter. Your individual life outside of work matters. So we are always looking, as I say, to get our mobile teams more in line with other first responders. There's a reason why law enforcement, EMS, and fire have a little bit better sustainability. They compensate at a higher rate because they understand they're asking people to give up the Monday through Friday day shift for all of this other complexity and after hours. And a lot of times, I think where we are lacking personally in our mobile services is trying to get our compensation up to par with that.
When I talk to police recruiters and say, well, what are you looking for in a young, a person who's interested in being a police officer? What are the qualities of person? It gets very vague. It gets, it gets kind of scripted and vague. What do you look for in someone who's coming to you and saying, I want to work for? How do you decide yay or nay?
I think one of the best things you can do is so many of our interview processes are closed end questions. And I get it. It's part of data collection. It's part of making sure we are equitable in how we are interviewing people. I'm not degrading the process, but I personally get more value from open ended questions, conversations. And
Hmm.
so for me, it would be, what are you looking to get out of this? Because I have met very good, very skilled people, but this isn't the right fit for them. And I don't want to begrudge them that and have them be dissatisfied. I think for people that we're looking for, it's people that really have a dedicated mission towards those who are suffering. And I think that sounds vague. You're like, well, isn't everybody dedicated towards that? Not everybody. That's not for
Yeah.
everybody. Certain people are better suited towards more stable cases, and we need that too. That is part of the continuum of care. So I'm looking for people that are energetic, that are passionate, people that have usually worked within mental health systems but are looking for kind of that next step of something with a little bit of unpredictability. We often talk
Hmm.
about scheduling. How tight are you to your schedule? And I always tell them, when you come in, you're going to have a schedule. It doesn't mean that's what you're doing for the day, because it all changes in crisis. We may have to pivot. We have to be fluid and flexible. I'm often looking for that as well. If people feel very strongly or they've had bad experiences in other jobs because of rigidity, which is fine in some careers, it's not going to be a great help here. And so we're always trying to focus on what's good for you as our prospective employee. What are you looking to get out of this? And the more they give me answers to that, Jason, that allows me then to say, okay, I think you'd be a good fit here, or you wouldn't. But a lot of it's mission.
So some of the most mission-driven persons that we can hire are people in recovery, people with lived experience of mental illness,
Amen.
veterans, people who are culturally centered. How are you integrating peers in your team?
We're very fortunate because as county, we are the crisis team, but we've lived in an era, we don't have them anymore, but we used to have a very large county hospital, a county psych ER. So we've had other services other than just our current community-based product. So we have had peers in and amongst us as long as I've been here, which is really good. I think the literature has started to really come around to show what many of us knew, which is that peers are a very valuable part of the system. And for people that were kind of late adopters to that process, I think now there is scientific literature stating otherwise. So I think we're finally at a point where we can all say, this has been going on long enough that maybe we should all be looking at this together. So I think most of our team has seen that progress. So we already have peers that we utilize for a variety of things. We still have a external project that we use peers for temporary case management. We
Hmm.
use peers in our crisis case management. There are peers at the crisis stabilization houses that we noticed earlier. We have a very strong peer presence at our outpatient clinics, which I neglected to mention earlier, but they are also part of our services. We have 3 different clinics specifically for the uninsured or the underinsured. And so that also has peers. So the next step is to get them directly on our mobile team, which ironically is what we're rolling out here in the end of 25, early 26.
Oh, fantastic. So we'll be able to check in a year or 18 months and say, how's it going?
Please do. It's something we've been working on for a while. And actually, the interesting thing is, I think we've had, at least for Wisconsin, I can't speak for other states, but there's peer certification that has been somewhat of a little bit of a hiccup.
Hmm.
There are people that are interested, but they are, for other reasons, can't get the certification yet. And yet we need to have So we've had the positions open for a while. We're just, what's holding us back is getting the certified people that are the right fit to make this roll out properly.
Yeah,
But I'm looking forward to it.
it's a conversation everybody has to, people doing this have to have with their HR department. Say, we're looking for somebody you may not think we're looking for.
Correct. And that's a whole nother. I love that you bring up HR, because I always say they're a partner in our hiring, but they shouldn't be the guide to our hiring.
Yeah, we're
They
looking.
they 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 get us a pool of people, but then we really need to get in there and decide what fits and what doesn't.
You think that's a bruise, and we think that's a burnish, you know?
Correct. Well, but I think you bring up a really interesting point that is a bigger national discussion, even outside of mobile services, which is how important lived experience can be. That's not to say that without lived experience, you can't excel at your field. But when people do have lived experience, to your point, that's a really interesting factor. It's not a rule out. It's not a concern. I'd like to know more about that. And I think that brings a lot to the table. And for the people that don't have direct lived experience, I think working in proximity to those that do gives them a whole nother education and understanding. Some of the best pairings I see, our mobile team always goes out in twos.
Mm.
From a safety standpoint, we don't solitarily respond. But I love seeing when people they pick up their cars right outside my office, so I can see who's going out on mobiles as they go. And it's always interesting to see a pairing of somebody with a little bit more lived experience, somebody who doesn't, because I'm just like, that's going to be a really interesting interaction to see both sides of that coin.
Do
Each
you have
side's educating the other.
do you have concerns about call types with people with lived experience, or any
Well, I think
trepidation?
I think it would probably be worth for me to call out when I think there's a difference between lived experience and you're employed as a peer specialist
Mm, yeah.
versus you happen to be a mobile team worker who has some background in this. I think that's a different story. But I
Hmm.
think when we're talking about peer specialists, I will tell you, I ran a psychiatric ER for about a decade when it was still a county project, and
Mm,
I did not want peers in that environment for
hmm.
that reason.
Hmm.
I had seen it go sideways. There was a level of acuity and re-traumatization that I felt that although they were bringing benefit to the service, I
Hmm.
thought it was more of a risk to them personally, and I did not like that trade-off. So I think there are areas where it can be complicated and you got to find the right person, or if not, you have the right supports around the person. But I think for most mobile work, we will keep a close eye on that as the project plays out. But I think we're ready to have them involved in most scenarios. I think the better thing there is whoever's supervising them, that they feel open talking about it.
Yeah, that's
And so where it's not a weakness to come back to us and say, I can't do this call. This just hits too close to home. We'll say, okay, that's fine. Let's pivot, get somebody else.
such an interesting point, and we're sort of verging here, but a lot of the training is focused on how to get the peer up to speed with the team, but also how to get management up to speed with managing peers, because it's different.
Absolutely. And it's one I would say that I don't think, and I can speak to myself as a manager of many years, I don't think there's tons of training on. I think we are all getting adapted to it, and which is ironic because in the world of being a mental health professional, we do know how to work with people that are living with mental illness. That's what we do. But how do you do it in this new, unique, I would like you to go serve and fit under certain certifications and training and best practices? I think it's a different world that we're all growing into. But I do think management needs to have a very close hand and have a good relationship with those peers so they feel safe in saying, I can't do this today. And that's what I always tell them. It's like, that's fine. I don't want you. I want you for the long run. I want you for the thousands of people that you're going to help. If that means we need to slow down our response on one particular case, we'll figure it out.
Okay, for the peer consultants watching this video, now you know here's another branch of work you can get into.
I'm like I said, I think 10 years ago, I would have said we all liked the idea, but we didn't have a lot of evidence behind it. Now, because it has become so much more ubiquitous, I think now we are in the data collection stage and people are seeing how helpful it can be. And what I like about it is a lot of the data is within systems. And otherwise, it's not in lieu of something. It's not, this is to replace something else. It's like, this is to augment previous practices that are already decent. Let's make them even better. And I think that's where mental health is in general. We are always a very multidisciplinary, multi-scope addressing of problems. And I think adding peers to it is a natural next step.
You spoke about tech a moment ago, and there's a lot of new opportunities to make use of tech in mobile crisis and in stabilization. What do you see? What are you using? What do you see that's helpful to you?
Well, because we are a very urban area. You can probably, for our county, which involves both the city of Milwaukee and then 18 different municipalities are part of the county, which is fascinating with our co-response teams, with our law enforcement teams.
Mm.
But as far as us needing to get to people, we can probably get end to end in our county in 25 minutes.
Hmm.
So we have had less need to rely on technology because we do most of our stuff in person. We still see, I mean, per month we're seeing 1,500 to 2,000 calls. That's a calls to our crisis line. So those are telephonic, but then in person, we're doing another 700 to 800 in person.
Mm.
So we can still get to most things in person, but we are looking into, to your question, virtual modalities for follow-ups. There's a big interest as we're trying to pay attention to the newer generation of appreciating that more than a phone call.
Hmm.
So we're just starting to investigate the options of right now. We follow up with anywhere from 400 to 500 people a month, just keeping an eye on how they're doing, connecting them to services, et cetera, et cetera. So we're not just seeing them during times of crisis. We're also trying to make sure they're connected to future services to mitigate the need for future crisis services. So for those, we're looking at some virtual modalities. I'd also like to see, we've used a lot of virtual modalities in our clinics for people that need our services but don't want to come to the clinic. They're scared, they're anxious, they're dealing with degrees of agoraphobia, or they're psychotic and their paranoia is precluding them from leaving the clinic at that time. If we can find a way to lay eyes on them virtually, we're looking into those modalities as well. That's worked pretty well. But for most of our mobile stuff, we're trying to still stay in person.
And this is fascinating to me that the generation has accepted screens so easily, and they're just comfortable with communicating, intimate things.
And more comfortable. I think that's the interesting thing. I'm not trying to judge your generation or my generation, but I don't think either one of us were raised with cell phones. So, right, me either. So I think it is interesting to us to see. I was just talking prior to this meeting in a separate meeting with our clinics about how we always used to consider virtual as if you can't come to us.
Hmm. Hmm.
Now we have to consider it from a patient-centered perspective. What do you prefer? And you'd be
Right.
surprised by how many 25 and younger say, oh, I'd much rather just do virtual. There's nothing precluding them from coming to us. There's no transport issue. There's no mobility issue. There's no time issue. They have time to do it, but they prefer the virtual modality. And so we're trying to lean into that as well, staying within our own best practices with our prescribers and the such.
Let's spend our last few minutes in telling me how Wisconsin works. Because you have 72 counties, all are operating under different ideas of what to do, very different parts, rural, urban, suburban. Tell us how Wisconsin works with mobile crisis.
It is variable, as you might guess, and that you alluded to. Whenever you have 72 different fiefdoms, I'll pick that word purposely, each one with a different budget and a different. So if I go up to really northern Wisconsin, bordering upon Michigan, their crisis services may be one person. Period. That's their staff is one person, and then everything else is outsourced to handle after-hour calls or the such. So it's hard to really say how it works unless you know which geographical part you're talking about. We don't have tons of interactions. We tend to operate within the borders of the county. I know myself and others at the state level have been advocating for regionalization in the future. I think there's a lot of benefit to that. I think there's a lot of synergy to that, particularly since we are all trying to recruit skilled people and there's only so many. For instance, down here in the southeast corner of Wisconsin, which is where we are, it's pretty populated. And so it'd be nice if we could also share our resources with similar large counties down here, like Racine and Kenosha or Waukesha, and they could share it with us. But because you have this county-based system, that's harder to do. And I think for the rural areas, it's even more potent. So as you get up into northern Wisconsin, it is predominantly rural. Mm-hmm. People may be 200 miles from a mental health professional. So anything we could do for those small counties to band together and try to create more of a consortium where they could share funding, share resources, share the very few cherished professionals that are in the rural area, I think that's to our future benefit. I can't speak for those counties, but I bet you if you were to interview some of the more rural counties in our Midwestern area, that would be their thought too. How do we pool resources? How do we maximize tech to reach more people more efficiently? For us, I think it's always going to be different for us, or I believe AMSA also has Dane County on there, a very good large crisis service out of Madison. We're going to be able to get to most people because we have the transport and the geographical proximity, and to be fair, the resources of a large city. Doing crisis services with us is a whole different thing than doing crisis services, 200 miles north of us. And I think that variability makes it hard to answer the question, but I do think the answer to that is more of a regionalized approach. I think the more regionalized you get, the more we can standardize treatment and share resources and support those who are less resourced.
Do you still have a state? I was at Mendota State for a little bit. Do you still have state hospital?
We have we have actually several state facilities, but only two that are large enough, I would say, to be called hospitals. One is Mendota, as you mentioned, that's in Dane County. That is currently predominantly only for forensic cases. So you have to be involved. There's a very small subset that they still use for civil, but most of it for the purpose of a reductive response is forensic. The other state hospital is in Oshkosh over on the eastern side of Wisconsin. That's called Winnebago Mental Health Institute. And they serve as basically the involuntary civil hospital for the state. So if you are being detained under our state statute in an involuntary hospitalized manner, and you don't have anybody local that you've created a partnership with to get them to, they end up going to Winnebago. So those are the two state hospitals we have left.
Well, Tony, this is a flood of information. Thank you so much for dumping on me. Let me understand Milwaukee and Wisconsin. Congratulations on 30 years plus, and looking forward to a next report on the integration of peers in your mobile team.
Very much so. Anytime I can, like you said, it was a lot of information. So, but 30 years brings a lot of stuff to talk about. So if I can ever come back and talk about, like you said, our peer projects, our co-response with law enforcement, any of our follow-up programs, which we're really trying to lean into heavily to make sure people feel supported, not just in the moment of crisis, but also thereafter, I'd be happy to come back anytime. Just let me know. We have a really, really wonderful team. I could not be prouder.
Take care.
You as well.